going to give a much less exciting talk than we just heard. It's switching over to clinically focused gear, and I think for the sake of everyone getting to their dinner, I'll go quickly through some of the clinical part. But today, I just wanted to give a broad overview for understanding the current genotypic landscape and vascular anomalies with a focus on lymphatic anomalies, and several speakers before me have done that. Become familiar with some of the new and emerging targeted therapies, and primarily to have the group and especially the patients and other centers learn about our consortium for the investigators of vascular anomalies, or CANVAS, and our planned upcoming VATCH trial. So as everybody has been talking about this evening, it's really important for our patients or our people that we take care of living with lymphatic anomalies that we are moving away from eponyms and we're moving more towards an improved classification system, and then ultimately towards a more genomic-based classification in the future. So we've been learning tonight about the various pathways involved. We know that the care of people with vascular anomalies and lymphatic anomalies really requires a bunch of different teams working together. And tremendous improvements from the world of genetics have really changed the game and how we can treat patients. So we've been talking about some of the various drugs that are now being used to target these known genetic variants. But what we still lack in the clinical realm is, well, who should get these medicines? When should they get these medicines? How should they get these medicines? And how do we know they're working? So I'm going to skip through the drugs for the sake of time. Except for this patient, because I think this is just a neat story. This is a patient, a CHOP patient with Noonan syndrome, which we talked about earlier, RASopathies, which are germline variants in the RAS pathway that I learned tonight have been known since the 1970s to have lymphatic anomalies associated with them. The novel work that is done in this field now is really allowing these patients to live a much more normal life. So this young woman had very severe pulmonary and gastrointestinal lymphangiectasia, and the identification of her RAS pathway variant, the identification of the MEK inhibitors being able to target that really allows her to lead a completely normal life now with minimal symptoms. So just a beautiful example of that. So the Consortium of the Investigators of Vascular Anomalies, or CANVAS, was put together by somebody else in this room, but I'm going to talk about it. So, so Dr. Denise Adams and many members of the American Society Pediatric Hematology Oncology group has a special interest group for vascular anomalies there, and people within that group started meeting back in 2013, I think was the first year, and started putting ideas together. And a few years into those meetings, people decided they really needed a research consortium to move some of these drug therapies into clinical trials and bring together all of the different people from across the nation in this room to do that work together. So that group has grown since the inception, and there are currently 22 different centers, as well as 2 advocacy groups, including, of course, the LGDA, as well as the Klippel-Trenaunay support group. So the leadership of CANVAS is Dr. Adams, with co-chair of Michael Jang, and then the treasurer is Eric Sandler, who's in Florida, and secretary is Yanela Yakubis. So the idea for this started back with what Dr. Adams calls the Tres Amigos Vasculares, or Dr. Adams, Dr. Brandau, and Dr. Trenner with the establishment of the Vascular Anomaly Special Interest Group back in 2013, the first fall meeting that took place at Cincinnati Children's in 2014. And then since then, there's been annual meeting of this group, both at the main ASFO annual meeting, the big meeting that occurs in the spring, and then a smaller group that occurs in the fall. And this is a list of the past sites, and we're all going to be meeting in 6 days again in Columbus. So in 2016, the group started talking about the possibility of this consortium. By 2018, they had selected the first sites and completed the bylaws by 2019. And then after Dr. Adams moved to CHOP in 2020, there was the first funding for the group, and then initial MOUs were signed. And as of our last big meeting this past spring, 23 of 24 formal contracts have been finalized. So through this consortium, we are trying to focus on and collaborate for clinical studies that are really important to our patients and families, and are trying to answer different clinical questions that we all have. So there is a COAG study, which is run by Joanna Mack and Shelley Curry at Arkansas Children's. And that is looking at the effect of anticoagulant drugs on quality of life for children and young adults with slow flow vascular anomalies. We are hoping soon that the Lullaby study, which is promoted by Taizo Nakano at Colorado Children's, and that's really looking at both clinical outcomes as well as several quality of life measures and some exploratory biologic measures in patients with complex lymphatic anomalies, getting combined therapy with sirolimus as well as zoledronic acid. And then the focus for tonight is really talking about the vascular anomalies therapeutic choice trial, which is we know as VATCH, and which is Dr. Adams' great idea and being led by multiple people, being co-led by multiple people in this room. So the purpose of the VATCH master platform is to create a clinical trial platform where we're going to start with 2 sub-protocols looking at alpelisib and trametinib, but to create the framework where other drugs can be put into the same framework going forward. So there's going to be a registry as well as a biorepository associated with the main platform. And then as we find additional drug and therapeutic targets, maybe proteasome inhibitors, those things can be incorporated into the future. So the registry part of the VATCH trial is going to be through a group called CASTR. And I think Dr. Vikala's group knows them well. So they have a great electronic data capture system that is based on the FAIR criteria for data capture and is used, I believe, by the whole VASERN network in Europe. The biorepository is something that we're really eager to develop. It's still in the initial phases of obtaining funding for this work, but through many of the scientists in this room and also online, we're going to try to be incorporating both biologic parameters, looking at is cell-free DNA, looking at tissue, and trying to track that both before and after treatment and throughout the trials. So the main objectives for the 2 sub-protocols for trametinib and alpelisib are to determine the proportion of patients with an objective beneficial response to either drug at 24 weeks of therapy. And what the group has come up with is really this kind of unique individualized response criteria. So we know these are not diseases that are cured. We don't really want to look at things like overall survival or complete response. So we've tried to put together a combination of things using radiologic measurement, patient-reported outcome measures, and the patient advocacy groups have been really key in influencing that. as well as what we've termed a clinical benefit assessment, and I'll give you some examples of that in a moment. And then, of course, as a secondary primary objective, looking at safety. Main secondary objectives are looking at biomarkers, cell-free DNA, and that's part of our exploratory measures, but also duration of response and tolerability over time. In each cohort, the trametinib cohort is going to be enrollment is going to be a little bit smaller than the alpelisib cohort, but from patients from 2 months of age up to 30 years of age, and with a clear vascular anomalies phenotype that fits into that category and a gene alteration in the associated pathway. And I'm sorry, I have a typo, but that is obviously supposed to be PI3K pathway for alpelisib. And all of these patients to enroll in the trial need to be determined by the treating physician at each center to have high-risk disease deemed to need systemic medical treatment. There is a washout period if they've been on other therapies. As we know, patients will be on other therapies, but there is no limit to somebody if they've been on selumetinib to coming onto the trametinib arm. Response assessments will be every 3 cycles with the main radiologic assessment at baseline, and then after 6 cycles or 24 weeks. And we've tried to standardize and streamline things as much as possible, but also knowing that the phenotypes for these patients are very wide and very different, and what's measured for one patient might not be important for another patient. And so each investigator that enrolls a patient is going to pick up front what the clinical benefit for their particular patient is going to be, and to follow that over time. So for radiologic response, there will be, of course, some patients who don't have radiologic assessment just based on their disease, but any of these modalities can be used, but then they just need to be followed at the appropriate intervals. The PROMIS measures, and if you want to know more about PROMIS in detail, you should pick Brian Sisbrain because this is his area of expertise. But the primary outcome is going to be looking at a global health measure with a physical health subscale. And then secondary, we're going to look at pain, interference, and then 3 exploratory aims looking at fatigue, anxiety, and depression. And then from the clinical benefit assessment, really, we have tried to give just examples, but this is not meant to be comprehensive. So some things that people might need to follow for their patients are laboratory parameters, measurement of pulmonary function testing, maybe it's body fluid drainage, maybe it's a bleeding rate, maybe it's an infection rate, or maybe it's body measurements. Response is going to be categorized into 4 categories: complete, partial, stable, and progressive. And we wanted this to really incorporate those 3 different response criteria. So radiologic assessment with the global health patient-reported outcome measure and the clinical benefit assessment. So the future goals for this VATCH platform is to really utilize the same methods or the same structure with some minor changes depending on the disease and the drug being evaluated, but to hopefully have a way that we can all collaborate to test these drugs and really know how they're affecting patient outcomes together. And then hopefully with the work of the scientists who are already involved, and hopefully more young people in the future, adding biorepository, adding other exploratory measures over time. This is the Canvas group at the last meeting, and any questions?